Hello. Yes, my microphone's working. I'm like freaking out now every time in case I've got no audio. So welcome back. I'm absolutely delighted now to be talking all things music. And this has come up significantly throughout the whole chat we've been having actually. I was just saying to Priya, it's just consistently been a message about singing and speech. And I've just never really come across that before, and it might be because we've got some music therapy students on the chat, but it might just be because it's something that's been more talked about during this pandemic because more people are using it as a therapy in this virtual age. So I'm not going to steal any more of your time. I'm going to ask you to introduce yourself, why you're here, what you do, and then we're going to have lots of chat discussion. Please continue to use the chat box. I know it's been playing up today, but it does tend to work once I put a comment in. So over to you.
Hi, I'm Priya. I'm a music therapist. I work for North London Music Therapy, and I also work for a SEMH school, which is social, emotional, and mental health. So I specialise personally in child development and mental health, which I think is fascinating. And obviously, mental health is something that has been affected so badly by this pandemic. The work that I do with North London Music Therapy has been really fascinating. We were really fortunate that we were in a position to be able to move over to remote working as soon as lockdown hit. So we didn't have a break in any of our sessions from face-to-face working to remote working from home, which I know we were really fortunate to experience. Not everyone was able to do that. And actually, we found remote working to be really successful. And yeah, music therapy itself, it's the easiest way I like to think about it is like a normal psychotherapy. Like a talking therapy, the process is the same. My thinking around it is the same. I'm psychodynamically trained. I trained at the Guildhall School of Music and Drama. So yeah, my thinking around the work is the same, but I use music as a communication tool in addition to words. Sometimes words aren't always so accessible. For example, working with a child with autism who might be nonverbal, they still experience all the same feelings that we do, but they find it more difficult to communicate what's going on for them. So music therapy is a really, really great way to be able to do that and help enable them to communicate what's going on for them, what's going on in their inner world. In addition to that, talking can be an element of therapy as well. And I found with some of my adult patients that I'm working with, some of our sessions have been all talking, which has really enhanced my skills actually as a therapist. Yeah.
So I think when people think about music therapy, they probably even go back a step and say, why? Like, why would you have music therapy? What would it be? What would be the benefit of? Like, what type of people would benefit from music therapy? Like, why does it even exist? I think people do. I think that's a concept that not many people know.
Okay, that's an interesting question. I believe that absolutely anyone can access music therapy, from babies. There are music therapists who work in neonatal intensive care, child development. In my training, I worked in a child development centre, working with children as young as 3 all the way up to 18. Like I said, a lot of the work is with autism, but there's many other reasons for accessing music therapy as well. Mental health being one of them, but all the way to older age, working with dementia. Actually, I think music therapy practices are slightly different working with dementia. So in practice that I'm used to, it's very improvisation based. Working with older clients or patients, you might access pre-composed music a lot more. It can help just trigger happy memories kind of in older age and stuff, which can be quite difficult. Yeah, it's really helpful in all walks of life, really.
You know, and it's that. Do you remember that clip that was circulating in the care home,
Mm.
and there was the most recent clip around how it links in with like your, from a neurological perspective, into your past and in terms of dance and movement. I
Yeah.
think it is. I think in terms of the therapy, it's massively under-recognized, hence it's underfunded. And
Yes.
that's probably one of the two links. That's it for allied health professionals. That's the problem, isn't it? If there's no scientific evidence base to show that it reduces cost somewhere in the healthcare system, you don't get any money to resource. So, but I think our healthcare is changed. If you think about how healthcare was first set up, to save lives, and it was actually all about health prevention, wasn't it? We had a national health service that kept the nation healthy. And certainly a lot of what we can do as therapists is part of that, in this psychodynamic model you talked about, which I love that word. But yeah, I think the work with children as well is probably really fascinating to people. So do you want to talk more about that? And do you know, I was listening to this podcast the other day, and it was a singer, and he was saying that he had a stammer. He wasn't English. I think he was American, and they don't get access to speech therapy like we would do as children. And he said it was only when he sung he realised he didn't have a stammer or a stutter anymore. So do you want to talk us a little bit about that, about like childhood music therapy and the then additional benefits it can have?
Absolutely. I've actually got a video that I can share. So I've got one child in mind when I'm talking about this. This child, I'm going to call her Hannah for the sake of this presentation. I'm not going to use her real name for confidentiality reasons. She was referred to me with a diagnosis of autism. She was considered to be quite high functioning, but she attends a special school. Her aims for music therapy were to improve her communication. She had a lot of difficulty concentrating and engaging in kind of prolonged periods of communication. It was also to improve her spoken language. She did have language, or she does have language, but it's quite limited. And she was also quite restless. So at the start of our work, it was a challenge engaging with her. I need to mention that this is someone that I've never met in real life. My work with her was entirely online. She received a grant through Jessie's Fund, which paid for 10 music therapy sessions with me, which personally I don't think is enough. It would be great if she was able to access longer term music therapy, but the 10 sessions that she did have were beneficial to her, and I was still able to recognise progress in our work. So yeah, her language was limited, and the clip that I've got to show you was actually session 9 out of 10, so it was towards the end of our work. And we're able to withhold about a 5-minute, quite intense communication, actually. It's back and forth. To an observer, it might sound quite repetitive, but for me, this was a breakthrough in her progress. It was really, really remarkable. She held concentration with me, and even through a screen, even through a camera, we were able to develop this relationship with each other. And I think had we been able to work face to face, that relationship would have been enhanced even more. Should I share it now?
God, I've got goosebumps. Absolutely. So we're going to share a screen and audio, people. So what would be really helpful in the YouTube chat, just to let us know if you can hear the sound. Just someone, please, that would be great. So yes, please share away.
So like I said, I'm going to refer to her as Hannah. I ask before I play this that no screenshots are taken and no recordings are taken of this video. It's confidential work. I have got consent to share it, but not to replicate it.
And if you're not watching this live, this will be edited out. So is that correct? We're going to edit it out, yes. So everyone watching live, you have a special treat.
Priya.
Hello, hello, hello.
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 Who's faster, please?
Faster. Hello, hello, hello.
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 Well, there's a lot of emotion in the chat box. Thank you so much for sharing that. Now, there's a couple of similar questions. Is there a different part of the brain that means that when people are speaking, they can't communicate, but when they're singing, they can? So,
that's a really interesting question. That's probably a better question for a neurologic music therapist, which I'm not trained in. But I do know that, for example, stroke sufferers who experience something called aphasia, which affects their speech, when using spoken language, it's quite slurred and quite difficult to access. However, I do know that singing, you use a different part of your brain to access your singing voice. So you'll find that a lot of stroke patients are able to sing quite eloquently, which is quite different from speaking.
thank you. Now, maybe this has answered this question a little bit, but the question was, can you walk us through what a music therapy session would be like and how it's changed during COVID? But that's kind of, so maybe talk about what a normal, or if there's ever going to be a normal, music therapy would look like. Maybe, and just give us a little example of things you might do.
So you'd have a private room that's set up with a variety of instruments. I've got my piano here, I've got a flute. Normally I've got quite a big toolkit of instruments, like I've got a xylophone, I've got a glockenspiel, I've got loads of percussion instruments. So it's lots of instruments that are really accessible for someone who's not necessarily a musician. I mean, the musical element in part is my job, because I've got the musical skills to kind of work with those. But anyone can access music therapy without needing to know how to play an instrument. So with a child like that who I've just shown you, I find it really helpful to frame the session. So you saw it was the start of the session with a hello song, and I've also got a goodbye song that I'd end the session with, and that allows for some continuity that can help settle anxieties that come with autism, for example, and the need for structure. And in between, it's quite child-led or client-led, and there's a lot of kind of matching what's in the room, lots of mirroring. So you saw there was that constant oh kind of vocal, but then there was a lot of different things going on the piano, and whenever Hannah would kind of play in a different way, thankfully she had access to a piano herself, so if she'd play in a higher register, I would join that. So it's recognition that I'm hearing what she's doing, what she's playing. When she'd play a bit softer, I would too. I don't know if that was picked up on, but it's really about attuning to what your patient, how your patient is presenting.
Thank you. And could you talk a bit about how Zoom has affected your practice with relying on turn taking and how you would play with leading or responding? And I think that's again linked into a couple of other questions about how this might change post-pandemic.
It's definitely been a challenge. Like when working on Zoom, there's always going to be a delay. So whatever music we play together isn't going to be perfectly in time with each other. So whatever I play, Hannah would have heard a few seconds later. So she'll be responding in time with what she hears in the same way that I'm responding in time with what I hear. And it's not a perfect setup at all, but it still worked. We were still able to build that relationship, which is what's more important, really. The most important thing in any therapy is the relationship between patient and therapist.
Thank you. And there's just lots of comments. I didn't even know that this type of therapy existed. There's some great comments around like premature babies and the use of neonatal units, also in the use of autism, and learning disabilities as well. So really, this is a therapy that can affect a huge variety of patients, isn't it? Now, how do you even, to get into music therapy, do you have to be musical? That sounds really silly saying that, doesn't it? But like, do you have to be able to sing or play an instrument, or is it something that you would learn when you go to university?
To be a music therapist?
Yeah.
There is a requirement for musical skills. So you need, for the course that I did at least, you need kind of a minimum of grade 5 on an accompanying instrument.
Oh, wow.
for example, piano or guitar, and you need to demonstrate a grade 8 standard in your first instrument. For me, that's flute. I personally don't consider myself a singer, but it's a lot of what I do. Before I started the course, had anyone told me that, I would have freaked out and kind of ran away with anxiety. But I've developed a lot of confidence with my singing since doing the music therapy training, because it's not performing singing. I'm not singing kind of in an operatic style. I'm not singing to impress anyone. I'm singing to form that relationship, and I'm using my voice in a really intricate and often intimate way to attune to my patients.
I mean, absolutely. I'm just blown away by this presentation. So, what are your thoughts on person sessions using masks? So it's like virtual almost better because we'd have to be wearing masks in person. And the last comment before we move on to Melody would be around, I love this. How would you envisage Hannah's progress? So masks, so mask face-to-face versus virtual, Hannah's progress. And is there anything you can't do online? Then we'll finish.
Okay, I'll start with that last question. Is there anything you can't do online? I think play pre-composed music in time with each other. It's possible, there's ways around it, but it is a huge challenge. In terms of working with Hannah online versus face-to-face with masks, I think would be really restricted because you can't kind of attune those facial expressions as much. It's a lot harder to recognize those facial expressions. But I have come across these masks that have a window in them, so that in terms of accessibility for people who rely on lip reading, for example, they would be really helpful. I think a face shield would probably be better because you can see those facial expressions a lot more, but they're not as safe as a mask that covers your mouth fully. Online working, we were able to develop this relationship when we've never met each other in person, but I think that relationship could have been a lot stronger. And again, through a screen, I can't see her body language as much. From the video that you saw, she's kind of like hiding in the corner a bit. I can't see her face fully. So there are restrictions with both, really. And I don't think I've got an answer for that without having tried both.
Thank you. That was all the questions, wasn't it?
I think, yeah.
Just to clarify, is the aim of the instruments to help facilitate words?
It's kind of help facilitate feelings.
Yes.
Yeah.
I love that.
A very accessible way to communicate when words are inaccessible.
Okay, so again, if you can access the chat, I really suggest you do, because there's so many nice comments about your presentation and about you and just about showcasing the role of the music therapist and the diversity that you have. So thank you so much. It's been an absolute pleasure. Thank you.
Thank you for your time.
And you are on Twitter, so we'll get your Twitter handle up once it's all published and downloaded. So thank you so much.
Bye.
And that brings us on to the amazing Dr. Melody Smith. Now, you guys are all in for a treat. Now, Melody has
her own
she has her own YouTube channel, which is very fresh. And she started a bit like how mine started. It's I'm not saying that you don't know what you're doing. I didn't know what I was doing. I needed to get rapid information out there. I was like, how can I do this for free? I don't want to advertise anything.
That's it.
I'm not young enough to be on Instagram, like you know.
I don't know.
I'm older than I look, Pen. I've got a Estee Lauder on. So I thought, let's do it. So I think the stuff you're going to be doing and are doing is going to be great. So I'm not going to take any more of your time. You're going to explain a little bit about the role of clinical psychology.
Yes.
Psychology is such a massive like area. And it's never been more important than it is now in this global pandemic. So over to you.
Oh, thank you. That's really kind. Thank you for that. That's lovely. And I genuinely am looking at you thinking, gosh, this is amazing. This is exactly what I'd love to be able to do. So I'm definitely looking to you. Thank you for doing this. It's been amazing. I think the benefit of being the last person to speak is that I've been able to listen to everybody else, and honestly, I've changed careers like 7 times in this talk. So thank you to everybody for their talks. So yeah, I'm Melody Smith. I'm a clinical psychologist. I do have a presentation, so shall I just go ahead and share my screen? I'm hoping that it works. Does that work?
That looks amazing.
Can you see me as well? Sorry,
we can't see your camera.
No, okay.
Hang on, but
I am a bit. Hang on, I'm not as up to speed with this as I should be. I'm definitely kind of more of a Teams person than a Zoom person.
It's okay.
But is it okay if you can't see me? Is there something I could do?
No. So I would just stop sharing again, so, and then turn your video on. That's it. Now start sharing your screen now. Oh, for some reason, so your video turns off when you start sharing, but that's okay.
Sorry about that.
It's okay. You look good. We can see your slides now. If you just start your presentation slideshow.
Yeah. Okay. All right. So yeah, just thought I'd give you a bit of a brief background about my career journey so far. See if I can put this on presentation mode. So yeah, just a quick background. So so that you, I guess for some of you, probably from other professions, so maybe you don't know what career path clinical psychologists take. So I started off, well, I guess I started off before my BSc, obviously, but that's the kind of first thing that sets you on your journey to being a clinical psychologist. So you do need a BSc in psychology or a psychology degree. I'll tell you a bit more about what you need with that as well a bit later. I did lots and lots of volunteering sort of throughout my degree, but also after my degree, and before landing my first role as a research worker. So part of my voluntary experience was at university doing research with some of the lecturers that I had, just sort of asking, can I do some work with you? And also I did a thin sandwich. So I did 2 6-month research placements. That kind of led nicely onto me doing some research work after finishing sort of my degree and doing some voluntary work. So I became a research worker, did some research into Alzheimer's disease, really loved that work. And while I was doing that work, thought, let me apply for the training. Didn't get on that year, so thought, okay, well, didn't get on, I'll do my MSc. So I did my MSc in clinical neuroscience while I was working as a research worker at King's, and the two go really well together, clinical neuroscience and working in dementia, because we learned about the brain, obviously, and in a sort of clinical way, so how sort of presentations occur, sort of what happens in the brain, etc. So it was really good. They went hand in hand together, and I think it really lent to later on when I did my doctorate, because we have kind of neuro modules and neuro placement if you choose to do that, and I had that background knowledge from doing my MSc. So it's not something that we have to do as a clinical psychologist or on the journey, but it's something I felt I really wanted to do, and I enjoyed doing that. After I did my master's, I applied again to get onto the training, didn't get on, so thought, okay, well, I'm going to get more clinical experience, more relevant experience. So I did more volunteering while working as a research worker for a little while, but I did change jobs. I worked as a clinical trials coordinator as well. Then a job came up. It was quite a good promotion job as a dementia case register lead. That title never meant anything, but what it basically meant is that I managed the team that I was in before. So I was a research worker before, going out, collecting data, information, talking to older adults, and collecting data essentially that would be used to understand the biomarkers of dementia, but also what happens in dementia, what the clinical progression is like, etc. And then I went on to manage that team later on. So I was just sort of handling a portfolio of studies. So I had a real kind of sense of what happened in sort of different types of studies, so clinical trials and other types of studies. And then sort of not long into that job, I, applied again and got a place on the clinical psychology doctorate, and sort of did that for 5 years or so. And yeah, now I'm a qualified clinical psychologist, and I work in CAMS with children and adolescents, but I work specifically with children with learning disabilities. And yeah, I thought I'd just put at the bottom there, not to scale, because this was a winding journey with lots of ups and downs, as all of our professions will be. So lots of people ask me how to become a clinical psychologist. So I guess I've talked a little bit about what I've done, but just in terms of, we all have our own separate journeys, and I know there'll be lots of people from different professions in this chat, but if it's something you're interested in, the minimum criteria is that you have a degree in psychology, and it gives you graduate basis for registration with the British Psychological Society, and that just basically means that it's on a list of university. So you've got your degree from a list of from a university that's on a list that says we've checked the standard of this course, and it's of the standard that you can apply for sort of registration for British Psychological Society, which oversees some of our some of the work that we do essentially, and sets the parameters for it. Or you can do an undergraduate degree, or you can do a psychology conversion degree, which I understand is 1 year. And then you need 1 year full time, and then you need experience working with service users, which I'm sure many of you will have, because we're all working in healthcare, but particularly service users with mental health difficulties. That's going to give you the sort of best experience, and there's lots of different amounts of experience that you need. I personally had a good couple of years under my belt of experience of working with service users, and the reason for that is not to get the number of years, but to really get that exposure to people, what difficulties they go through, and have a chance to sort of muddle through some things, see how it all works, and get to understand how some of the things that you learn in your psychology degree can be applied in practice. And of course, being around sort of other types of professionals and how they work, all those things really contribute to you getting that good experience that you can get a place on the course essentially. And of course, a research experience is helpful as well. We're evidence-based practitioners as clinical psychologists, as many allied health professionals are. I think all of them are, and so we are very hot on research, and we do a major piece of research during the doctorate called a thesis. So we need to have some of those research skills coming into the course. The core skills that we're looking to develop before going on the course and through our entire journeys as clinical psychologists is really just empathy, active listening, ethical practice, thinking about, if there's a situation kicking off, what's the best way to respond, and being able to kind of access parts of your brain that tell you, yeah, I'm going to respond in this way, so that it can kind of go, situations that could go pear-shaped could go as smoothly as possible, if you like. Compassion, of course, caring for other people, trying to put yourself in their shoes and understand what's going on for them, and sort of removing as much as you can your own personal experience, putting that to one side, and allowing that person who you're working with to really take center stage. Robustness, by that I mean, as clinical psychologists, we can be quite scientific, bit clinical, clues in the name, in how we approach things. So we're evidence-based basically, and resilient. So we're obviously hearing a lot of difficult stories, a lot of things that people have gone through that are sometimes horrific, and it's, again, like other people have said, not to scare people, but it is the reality. If we're not developing that resilience within ourselves to look after ourselves, but also to cope, then you'll burn out really quickly. So I'm always banging on about, we need all people from all walks of life, especially people from Black and minority ethnic backgrounds, but all the protected groups, and just anybody really, because we work as clinical psychologists, we work right across the lifespan with all different types of people. And so, it's just great to have a diverse workforce that we can all feed in and serve a diverse population, basically. So a little bit of a note on volunteering, because it's a bit of a bugbear of mine. I found that I did a load of volunteering, lots and lots of free work. So not only did I work for third sort of voluntary sort of companies and organizations like Mind or Samaritans, things like that, but I also just did free work, like just for sort of lecturers, or just for anyone that would would possibly take me, really. And I think it's great that people are proactive, you know, particularly, you know, people in psychology are proactive and, you know, looking for opportunities, and it's very important that we do look for them. But I think there's a balance to be struck between not volunteering forever and ever, but just getting enough experience, because one of the problems is that with clinical psychology and assistants is that they get locked into this kind of volunteering, and sometimes it's you just get trapped, and I want people to kind of move forwards and be paid for the work that they're doing, basically. So just try to be mindful of that. If you are on a journey to become a clinical psychologist, you want to be thinking about how you're, you know, funding your way, and just be mindful really that you don't get locked into doing lots and lots of free work. So the doctorate training itself is 3 years. I did mine at the University of Surrey. It took me 5 years to complete it. So that's a bit of a testimony to, you don't have to be perfect. Things happen in life, and I won't bore you with the details, but you can take a bit longer, and it's absolutely fine. Usually it's 3 years. I did mine at Surrey. It is a paid training, which is part of the reason why it's so competitive to get onto it. I mean, it really is competitive to get on. And part of the reason is because it's paid at band 6, and band 6 in the UK is probably just under sort of 30 grand, sort of is 27 grand or something like that. But it's, you know, a very kind of varied training. It's very intellectually stimulating training. We get lots and lots of input from lots of different people, professionals, you know, specialists in their field come in and lecture us, you know, so it's really rewarding. We're getting really lovely knowledge, interesting knowledge, and we're able to go out there on the placements, because we have placements as well in addition to lectures. We have placements where we go out and we use the things that we've learned and put them into practice, and you know, do that under supervision of a clinical psychologist as well. So we're getting that kind of lectures in the, you know, in university, but also that on placement training, live training that's happening. It's a really great way of learning sort of through experience. I did 5 placements. At Surrey, we do that: an adult one, child one, a learning disabilities one, an older adult one, and I chose a specialist neuro one because I just like neuro. Other people choose other specialities. You know, for example, you know, somebody chose one on, I think, in the military. We also do assignments in case studies. So yeah, and a thesis that's 10,000 words, which is a large research study essentially. So we're quite busy throughout our training. It's quite stressful at times, I'm not going to lie, but it really does grow you and stretch you and prepare you for actually quite a fast-paced healthcare environment, actually. So I'm grateful for it. So what do clinical psychologists do? So we assess and we treat mental health difficulties kind of in the first instance. That's kind of our main remit. We work with people who are struggling with their mental health, essentially. Most common mental health disorders are anxiety and depression, as we know, but we also work across a variety of presentations, from trauma to eating disorders, you know, and we can work again across the lifespan. So from, you know, under 5s all the way up to sort of, you know, older adults and, you know, and sort of hospice care, that kind of thing. So right the way up to, you know, the right across the lifespan. There are you know, a variety of models of treatment that we use, and a variety of models of assessment that we use. I guess one of the main therapies that we use is CBT, cognitive behavioral therapy, and I hopefully will do a video on that for my channel at some point soon, so I won't bore you with the details of that just at the moment. But it's a really great evidence-based therapy. It doesn't work for everybody, but it works really well for kind of depression and anxiety in lots and lots of people. We don't just treat mental health difficulties. We also are interested in behaviours. And that especially comes into my job, which I'll talk about in the next slide. But if people are struggling with specific behaviours, or perhaps they're interpersonally not doing great, so they're not relating to other people that great, we can sort of do therapies and work around that as well. So family work, group work, you know, individual work, kind of working in different ways. And the aim is to just improve people's quality of life and to alleviate mental health difficulties and problematic behaviours, essentially. Yeah, so I've spoken a little bit about our skills, but yeah, most of the time what we're doing is talking therapy in a sort of individual format or in a group format, and sometimes we do some behavioural therapy, so sort of just changing what's happening in people's environments, and I'll talk a bit more about that in the next slide. We also do clinical research, so some clinical psychologists just work in research. We do research sort of in our practice as well, although sometimes it's difficult to find time to do research, but we really try our best. And service development and leadership as well. So one of the key kind of themes that runs throughout clinical psychology is leadership, and we learn a lot about group dynamics and making change happen, etc., in teams and groups. And so we can use some of those skills and some of that knowledge to influence change in our services, and make sure that we're moving things ahead and steer change and improvements. So I work in, so a bit about me, I work in CAMS LD, and I work with mainly kind of what we call tier 2 to tier 3 cases. So these are kind of cases that people that are having difficulties but need a bit more input than self-help. The self-help wouldn't quite be enough, but could do with some support from sort of one clinician. So I work with people and families like that, but also sort of families that have multiple difficulties going on, or perhaps they've got multiple children in their families who have learning disabilities, or things that are going on that are more complex in their households. And I work around, as I said, mental health, so helping children with learning disabilities who have also have anxiety or psychosis, and helping to manage that anxiety, or manage psychosis, for example. And I do that in collaboration with my team. So for example, I'd work with a psychiatrist, and we'd both be working hand in hand, helping this family to alleviate mental health difficulty. But we also will help with behaviours. One of the things that Priya, I think it was, saying before, was that children with learning disabilities are often non-verbal, and so they will express what they need via their behaviours, and sometimes that's behaviours that challenge, so like banging things or hitting and things like that. And so I work around behaviours like that, and helping parents to understand and formulate what their children might be expressing, and how we might be able to meet the needs of the child without them needing to present with this behaviour that challenges. So that's the kind of work that I do. I also do care coordination, so that means that I'm sort of maybe not therapeutically working with the case, but I'm holding the case and representing the child from a mental health psychological perspective, so sharing a formulation around the child that helps us to understand what's going on socially for that child. So an example could be if, for example, a child, their current mental health was stable, but there was a network involved in helping that child and their family. So there was a social worker, maybe there was a support worker at school, maybe they went to a special school, so they had special classes. It might be that there needs to be a mental health perspective on how that child would benefit most from being at school and being at home, etc. And so I'd hold the case, but not necessarily have any input therapeutically, because the mental health side of things is being managed. I hope that makes sense. So the work that I do is very interesting. It's intellectually stimulating. I get to work with lots of different people, even in the pandemic, and I'll go on to say how the pandemic has changed this in a moment. People always ask me about how much psychologists get paid, so I always put it in there if you want to know. Yeah, really great to be able to work in a team. I guess, working with a variety of professions, and also working in a team for the child as well, so with parents and with schools, etc. So I get to work with lots of people. That's my own personal role, but clinical psychologists, work, as I said, in lots of different settings, and there may be sort of differences there. So how the pandemic has changed my work. So I think the main thing that comes to mind is that there is a change in the intensity of the work. So I'm finding that within our service, so I work in a child and adolescent mental health service, and I work in the learning disabilities team, but there is a wider service. And within our service, we have found that we have had to sort of really manage the complex and urgent cases first, and then the consequence of that is that there is a backlog of other cases that we're now sort of trying to sort of get up to speed with and get back up on, and I'll sort of go into how we're doing that in a moment. But what at the beginning of the pandemic, what we were finding is that there was a lot of crisis, and we were needing to really support the crisis team to support the young people that were really finding it hard, all the changes hard. And that's meant that we now have a sort of rota system where we essentially work on duty. Everybody in the service works on duty now, and we take that in turns, and that sort of spreads the load a bit, so that we're feeling that, you know, a bit less intense for us all. But yeah, I'm finding that sort of with my LD work, there are sort of people are stuck at home. If there are behaviors that challenge present, you know, those behaviors really become unbearable very, very quickly, and so we need to get in there and act very quickly. If we don't, then things kind of kick off. So finding that things are quite intense, we really need to act very quickly with certain cases in order to, you know, keep things kind of calm or manageable, I suppose. We as clinicians and have needed to take time to reflect and really be conscious about taking that time to reflect. So what we do in our team is we have a allocated time every once a month where we reflect on a big topic, and then we can sort of check in every week, at least once a week, about how the week has gone. And I think other people have spoken about that as well. And you know, it's really tricky. You know, people have talked about, you know, sometimes it hasn't been a great week. Sometimes it's been really hard. It's very intense and it's very fast paced. And so yeah, we've needed to make sure we have that allocated time to reflect, but also we can always check in with each other and you know, just make sure each other is okay and reach out to each other if we're not feeling great. We've needed to be even more flexible and compassionate. So I work in LD, you know, working flexibly is, you know, just normal for us. We must, because we have to make sure that we're making those reasonable adjustments for people to access us. But now I've found that, you know, there are so many more barriers at play, and we need to really be working very actively to remove those barriers. Somebody earlier talked about that that this pandemic is making it clear who has and who hasn't, and really creating a gap between who has and who hasn't got. And so we don't want people who haven't got time or who haven't got space, or maybe, you know, who are feeling really tired, to access us so that they can sort of benefit from what we have to offer. And we need to do that, and we want to do that in a really compassionate way, so that people can connect with what we're trying to do for them and not feel like we're just trying to hound them. We want it to be kind of in a way that's kind of inviting for people, and but also trying to give people the opportunity to say if they don't want our work. It's quite a fine balance actually, but you know, just being very mindful of that process and allowing that to happen. Everybody's talked about being creative, so you know, we have been creative, but I think just as an example, you know, we're now doing our group therapies online. You know, we in our service were the first, so I'm just boasting, but in our service we're the first to set that up and be able to kind of have that interface on Teams and try to create that dynamic between, you know, the parents that are taking part in our courses that we offer, or our education that we offer, or group therapies. You know, be creative about how we make that happen. So using the chat functions, and you know, allowing for parents, if they want to create WhatsApp groups, they can converse after the groups, for example. You know, these kind of things are really helpful to helping us to be effective and let the children get out of what we do as much as we possibly can, because you know, we just can't get out there anymore to see the young people anymore. I used to do lots of observations, going to schools and see young people in their, you know, home environments, and now I'm having to really rely on, you know, parents recording things and, you know, being creative and trying to get the information as best we can. But also, you know, just a note on being a bit more vigilant. So, you know, people who are really struggling aren't going to be able to present to us potentially. You know, there is that really harsh reality that we are missing some people, and it's an awful thing to think about. And so, you know, being really vigilant, you know, listening out for any kind of risk issues, and really being supportive and compassionate and helping people to disclose them and to get them the support that they need. But it's very tough because lots and lots of things are closed. But, you know, it's not all doom and gloom. Some children do prefer social distancing. So I remember, I think there was somebody earlier who was talking and said they're a bit, you know, more of an introvert, and, you know, social distancing is actually really nice for them because they don't have to kind of be dealing with kind of lots of social interactions and the unpredictability of people as it is, you know. And that's definitely true of our children with some of our children with autism, who are on autistic spectrum, and some of our children with a learning disability too. So, you know, for some of them, it's they're having a great old time being at home. Some are able to still, you know, well, actually, I suppose for some of the children, there is going to be a real harsh reality when we go back to school. So we're already preparing for that. You know, going back to that routine is really, really tough for our children in particular. But you know, we'll enjoy the lull while it's happening for some of our children, because we have no other choice really. Again, another good thing is that we've become more digitally adept. So I've really upped my digital skills, although they are still probably below par. But I really have, I promise you. I've, you know, figured out how to do kind of questionnaires online, and, you know, now, you know, I can sort of teach parents how to get logged into Teams, and, you know, written some nice how-to guides on how to do therapy online. You know, how we're doing therapy online is amazing actually, and some people can't access it because it's online, but some people will only be able to access this kind of therapy, and that's an amazing thing that I think we've now got access to forever and ever. That will continue, you know, because some of our parents, they can't get out. It's a bit difficult for them. And so I hope that really will continue. And of course, I've started a YouTube channel to help aspiring clinical psychologists. So that's, you know, something that's really come out of this pandemic. You know, being more connected in that way has really highlighted how much there is a need for that. And so hopefully I can bring some more content about that and help people as they're moving forward on their journey if they wanted to become a clinical psychologist. So that's kind of my whistle stop. I hope I did talk quite quickly. But yeah, if people want to kind of get in touch with me, I am on Instagram. I'm probably too old for it myself, but I'm on Instagram, and I, you know, as I say, started up a YouTube channel, so do have a look after, you know, when this is finished at some point. And I've also included some sort of websites there, so that if people were interested in getting sort of more information about what is needed to become a clinical psychologist, and yeah, more information for sort of peer support, people can look on those websites. Thank you for listening. I'm going to come out of it so I can see.
So you can see us.
You can see me.
So yeah, the YouTube channel couldn't be easier because it's a name. It's Dr. Melody Smith. So that's amazing. Right, we are going to have to bash through these questions, I'm telling you, because there is a lot. But the great news, and you're on so many social media platforms. The great news is you're so reachable. Yeah.
Honestly, people reach out to me, which is why the whole thing started. So do reach out to me. So yeah.
Are you ready?
I'm ready.
Okay. Can you touch on dietitians and clinical psychologists working together?
Oh, that's a really interesting one. So definitely, I don't work in physical health, and so I might not be the best person to answer this, but I know that is something that can happen in at least in diabetes. I would imagine so. But otherwise, I'm not sure. I think when it comes to kind of diagnoses or kind of life-changing diagnoses or lifelong conditions, psychologists will be there. So if there's a dietitian in that as well, then we'll probably be working together. And that would be such interesting work. I'd love to do it.
It is. And so there's, for me, just with my I'm managed psychologist in a couple of different jobs I've done. Some of it's around health psychology, so behaviour change when it comes to food. Some of it's around patients who are needing like enteral feeding. So if you think about some of the CFs or patients with neuromuscular disease who might have problems with tubes and being in the body and things. So there is huge potential there, like you said, Melody,
Absolutely.
in terms of
And
that
also in
crossover.
eating disorders.
They're underfunded. Psychology is underfunded, and this is the thing. It's the benefit of actually when you need interventional, or you can change behaviours through therapy, that you then reap the benefits financially tenfold.
It's that old thing, isn't it, about proving your worth? It's really tough, and I can't bang on about research enough, because it really, really does do that. It evidences our worth. Just very quickly, I was also going to say, obviously in eating disorders, we'd have dietitians as well there. Again, I don't work in eating disorders, but I'm sure there is lots of collaborative work happening.
How does a clinical psychologist work differ from that of a psychotherapist?
Yeah, so I guess a psychotherapist is a really difficult question to answer, because we overlap massively. So as I understand it, a clinical psychologist is trained via that route. It's a very specific route via the NHS, and we are trained in multiple models, including neuropsychology. And we use, although we don't do wonderful things like music therapy, which I love music therapy, and we do use different ways of intervening. And as I understand it, psychotherapists might have one core model that they use, and it's usually a talking therapy, whereas as a clinical psychologist, I don't always use talking therapies. I might use something called positive behavior support, which is about looking at behavior and helping the network to change the way that they behave around somebody else to then impact on somebody else's behavior. I hope that makes sense?
No, it does make sense. There was a couple of other people that had commented. So there's a lot of just statements saying we need more of you. I think we know that, especially with the mental health crises, especially with the impact of COVID-19 and the pandemic. Now, this is a really big question. Now, so I'm kind of going to answer it as I say it from a management perspective. With regards to using empathy in practice, developing resilience, I have a bit of a problem with that word, and avoiding burnout, do you have any suggestions, strategies that we can use in practice now? Well-being and access to well-being at work and for students should be a priority for every employer at the moment. So you should have access to well-being sections on your student web pages, in the hospital, and as a student you should be able to access that. As a student in a good hospital, they should give you all of the benefits that staff have. Now there is also free stuff online as well, isn't it, through some of the charities, there's NHS specific providers. That would be my management head. Melody, over to you.
Yeah, exactly that, and it's a great question, because it's really highlighting that you're prioritizing that. I think that's the key thing, is that you're aware, is that people are aware of their own mental health, and that they're asking questions about where they can reach out for support. So really have a think about what is available to you at the moment, and where do you get that support, and what more do you where are the gaps, what more do I need? As you said already, Rachel, universities should have a sort of pastoral care or some sort of well-being service available there. There are sort of lines that if people are in crisis, there are sort of Samaritans, and there are sort of charities that people can call if they're really feeling kind of things are really getting really tough for them. But the first port of call, I would say, would be to go to your university pastoral care. Really, I think they as much as I've experienced them, they've been great.
Thank you. Now I'm going to group 3 questions together as the final one, so get a question in, anyone, if you want it, very quick. Is about funding, and you're very new into your career and I'm very old into mine. Well, I say old, 20 bit years. Funding. Have we seen increased funding for clinical psychology as part of the long-term plan and part of the pandemic? Now, if we think as part of the pandemic, the role of the clinical psychologist for me is definitely in the follow-up recovery stage, as well as the acute phase. We'll keep that kind of separate. But most of the best interventions are when people are out of their acute phase. We know that with delirium, etc. The answer is no. There's been this 10 million, but that's a drop in the ocean for post-COVID recovery. I work at quite a national level, and I haven't seen any commitment to funding yet for any of the therapies. So, but I'll pass that over to you, Melody, for your opinion as well.
Yeah, in a word, no. But it's difficult, isn't it? Because we are in the middle of a pandemic. Sort of, okay, there might be a bit of light, but we're not quite there yet. So who knows? I'm a stickler for being hopeful. The year on year, we have around the same amount of places, if I'm honest with you, for trainees. And so no, there isn't really a huge amount of money being plugged in, unfortunately.
Do you know what's really interesting though, and I don't know what your opinion is that students and newly qualified are much more aware of funding now and the importance of resource. When I think back to when I first qualified, I wouldn't have never asked that question. I would never have. Isn't it interesting?
That is a very good point. It's definitely something we thought about when I was training, but it's not something I thought about before training, actually. And that I think it's important actually that people are thinking that way, because it's the reality. And I think if people are thinking in that way from the beginning, that I feel like that's a bit of a leadership kind of competency, having that oversight around funding, and that's a factor in what we do. And so I think it's not a bad thing. It's not a bad thing.
Okay, I mean, you are doing so many amazing things already. I can't wait to follow your journey, being qualified,
thanks.
honestly. There's just one final question popped up. Is it possible for psychology undergrads to get direct experience in clinical psychology or shadowing a clinical psychologist? This comes up quite a lot because there's a lot of patient confidentiality issues and
it's very challenging to get that direct clinical experience. So you absolutely must have a CRB check. Absolutely. And I think everybody else does anyway. But if you're not in the organisation, that becomes a bit tricky, which is why I talk a bit about volunteering. So you can get into the organisation via volunteering, but what can happen is that you get a bit stuck in those voluntary roles. But I personally wouldn't have somebody in my therapy sessions unless my client has very clearly said, I don't mind there being someone in there, and I'm okay with it kind of not affecting the dynamics, because it's, as you say, it's a very tricky balance. Sort of when you have a therapeutic relationship, you want to maintain that. And so, yeah, it is really difficult to get that experience. But there are other things, there are other ways. So you can work for charities, as I say, like Mind, and do sort of bits of work, or, go to workshops and hear about how other clinical psychologists work. Of course, stay tuned on my YouTube channel. I'll hopefully upload some videos on there about kind of what I do in the therapy room, because I understand that is kind of like an enigma for people and they want to know what's happening. So thank you for that question.
Thank you so much for your time. You've been amazing. Really, thank you. Obviously, I think there's more questions still coming in, so we could go on for hours.
Yeah.
Please reach out on social media. And there's lots more to come. Watch this space.
Yeah. Can I just say as well before I go, thank you so much, Rachel, for putting this on. It's absolutely amazing. I wish I had something like this when I was a student. And so yes, thank you so much for putting it on.
We need to work together, so thank you.
Yeah, honestly, thank you.
Now
Bye,
we're going to take a really short break, like 10 minutes. So if you could come back at 2:20, we will be live streaming the pathophysiology and the physiotherapy talk. You will be able to watch them back if you need to go, and we'll have them in a specific section. But 2:20, come back here for pathophysiology and for physiotherapy. Thank you so much. Just sign in the usual way on the HP Leader YouTube channel.